Hello and welcome to today's webinar, Time to Improve Your ED Throughput, 5 Steps to Select the Right Technology. Today we will be discussing current overcrowding trends and issues affecting ED throughput and 5 steps that will help you select the right technology in order to improve your throughput. My name is Ann Beatty, I'm T-Systems Senior Marketing Coordinator, and in just a moment we'll be joined by our presenter. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We will gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with you one-on-one. We will have a recorded version of this webinar in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. And now leading our discussion today is Dr. Maureen Anderson, Physician Executive for T-System. Dr. Anderson is a practicing physician at William Beaumont Hospital in Troy, Michigan, and a physician consultant for T-System. She works with clients to help them leverage our products to optimize clinical quality and efficiency. And now to kick off our presentation is Dr. Anderson.
Thank you, Ann. Good morning or good afternoon to everybody. Thank you for joining us today. You're really picking a good time to look for an ED information system because at this point plenty have gone before you. In a survey of 21,000 docs across 25 specialties, in 2009, 30% had no plans to implement an electronic system. Now there's only 6% that have no plans, and 82% are currently using or planning to use a system. So you have a large body of collective wisdom and experience that you can tap into to help you make a great decision. As you know, it's not just selecting technology. You really want to use this opportunity to look at the bigger picture. How are we doing now? How are we serving our patients, our community, our colleagues in the outpatient setting and the inpatient setting? How are we doing among ourselves, and what would we like to be doing? And when you have that picture in your mind, that's going to help you make a better decision about the technology. So today's talk is focusing on selection of the technology. Part 2 of this is talking about process improvement, leveraging that technology to optimize flow through the emergency department. So I think we all know that a long length of stay has a number of negative implications, patient safety being first and foremost. We all know that longer waits increase morbidity. And you may have seen the study that showed that emergency departments who are on diversion for several hours have higher morbidity and mortality relating to acute MI at 30, 90 days, 9 months, and 1 year. Obviously, there's a revenue impact. Each time a patient walks out the door, that's $300 to $500 leaving your system. And each ambulance diverted represents a loss of at least $3,000, bearing in mind that most of those ambulance patients are admitted. And the biggest impact is on patient satisfaction. As we know, the time from arrival to seeing the provider is the one most important to patients. And there's really a cascade effect when you have an unhappy patient. 75 out of 100 dissatisfied patients will talk to their family and friends about the experience, who will turn around and talk to their family and friends. So one negative experience potentially impacts 465 potential patients. There's a lot of things going on in healthcare that are further exacerbating the throughput issue. Healthcare reform has many positives. I'm not going to get into politics, even though it's close to election time. But more insured patients does not guarantee that these patients will have access to health care outside of the emergency department. So this has the potential to impact our volumes. Meaningful use is promoting the use of electronic health records. However, there's no guarantee that those electronic health records will support ED processes. I don't know how much exposure you've had to the ICD-10 initiative that's coming along in the future, but there is going to be a requirement for more specific information to be documented in order to be paid. So just an example of that, a fracture of the radius and ulna currently has 27 5-digit codes in the ICD-9 system. In the ICD-10 system, for a fracture radius and ulna, there are 2,960 potential 7-digit codes. So you can see that the complexity and specificity is going to have to be managed. It's going to need to be documented in order for your reimbursement to be maximized. Accountable care organizations and initiatives to keep patients in network also have the ability to impact the emergency department. Now here's the good news. If you're able to impact your length of stay in a favorable way, there are many benefits in terms of quality, patient satisfaction, and of course revenue. So let's look at a 50,000 visit ED with an average length of stay of 200 minutes. And let's say that the physician group bills about $100 per patient and the facility bills $500 per visit and $3,000 to $7,000 per inpatient admission. If you're able to reduce the length of stay by 60 minutes, and granted that's a very optimistic goal, but it makes the point, that gives you 50,000 hours of increased ED capacity per year with 21,000, almost 22,000 potential new visits. The physician revenue can increase by about $2.1 million. The facility revenue could increase by 8.6 million, and then 13 million for admitted patients. So it's a worthy goal to pursue, and we want to make sure that the technology you choose really supports that goal. So there are a few steps to selecting the right technology. You want to have a good representative team. You want to figure out what your needs are. You want to, based on these needs, look at what attributes you want to evaluate in the system. You want to understand the requirements both of the vendor and of your facility for this project. And then you want to measure and document the ROI. So as you can imagine, a good information system will not fix everything. You need leadership, process, etc. to factor in. But a bad information system can certainly grind the emergency department to a halt, which causes great dissatisfaction among patients, but also among providers. They're feeling like they're spending more time on the computer than they are with patients, and that's not why they went into this business. All right, so who needs to be involved in this team? Obviously, you need supportive and engaged leadership. Your CIO needs to look at how the ED information system will fit the enterprise system strategy. How will resources be utilized? How does it support the key priorities of the facility, such as meaningful use, ICD-10, ACOs? Your CFO is an important person here. What financial savings and growth will result? Is there funding for training, upgrades, ongoing costs? CNO, CMO, how will a system support quality initiatives, care coordination? You also want to have other key stakeholders that may not be in the C-suite and may not be in the emergency department, but are very instrumental to the patient care process. HIM and coding is an important aspect. You also would like to include representatives from lab, radiology, maybe even a hospitalist or an outpatient physician. The ED medical director must be involved. They're going to want to be looking at the physician group impact, productivity, reimbursement. The ED nurse director will want to know if nursing initiatives are supported, and they're going to be looking at workflow and making sure that a system supports the workflow initiatives. You must have frontline providers involved, because with all the bells and whistles in the world, if the frontline providers are not using the system, the rest is not going to be as beneficial. We have seen clients, not ours of course, but others, where they have all sorts of functionality available, but it's very difficult to use. So the physicians might be just typing or dictating. So that facility is not able to reap the benefits afforded by that system because it's not being utilized by the frontline providers. And when you bring this group together, it's important to have a variety of perspectives, meaning, of course, you want your proponents. You want a cheerleader, a champion, but you also want the pessimist. You want the person who's thinking worst case scenario, because that perspective is valuable. You want to include at least one computer illiterate person. In our case, that was me. And you want to make sure that they can also use the system. You want to assess your readiness for change. Timing is everything. You don't want to wait till you're under the gun. Your current system is being sunsetted, or a new system, hospital system's coming in, and you have to quickly make a decision. You want to give yourself time to fully evaluate and make a good decision. There's a couple things that contribute to resistance to an electronic system. One is cost, one is culture change. I think change in general is difficult for many people, it seems, physicians in particular, which I guess I can say, being one. I recall when I was taking over as medical director for one of the Henry Ford EDs, so it was a 50,000 visit freestanding ED, and they had been dictating for 3 years, while there was one person in there who was still handwriting charts because she just felt like she wanted to see the documentation in front of her and didn't want to let that go. So change can be difficult, even though it may look to be changed to an easier process. You see that as a facility and organization, you want to have clear vision, direction, and goals. When you decide to go on a vacation or a trip, it helps to know where you're going before you make your plans of how to get there, where you'll stay, etc. So really having the end in mind is very important. Strong, committed, engaged leadership. And you notice this is here at the facility and organizational level as well as the ED level. A strong leadership team is absolutely crucial. One who is very good at change management. The leadership needs to effectively help the group navigate through these transitions. You want to make sure that as an organization you have the resources, both financial and IT. And of course, whatever you plan on, you may need to double it. But you would rather overplan and underutilize than underplan and overutilize. So you want to take a look at that. In the ED, you want to look at how willing your staff is to implement new technology. And part of that may relate to where they are in their careers, how they're compensated, and certainly staffing levels. If the staffing levels are very low and the staff is stretched very tight, they are not going to have a lot of patience and support for something new. You also want to look at your ED space and layout. There will be new needs in terms of computers and needing space to document. So you're going to want to look and make sure that it's appropriate for the project you want to take on. So again, as we mentioned before, you want to know what outcomes you're looking for and which ones are most important to you. And it's important to understand the motivation that each member on the committee might have for accepting new technology or not accepting new technology. And then making it clear to each member how new technology will be of benefit to them personally. It might be a clear benefit to administration, but the frontline providers don't feel like it would be any benefit to them. If that is the case, that often doesn't go well. So you have to make sure you're communicating to all members how they will benefit from implementing the technology. You want to look at potential project barriers and figure out a strategy for that. Technology proficiency and adoption is a big one. Now, when we went live with T-System back in 2002, we were very early adopters at Henry Ford. We had a number of seasoned providers, and we were not sure how well they were going to be able to use the computers. However, probably our most seasoned provider, who's left-handed, which I am too, so that's not a negative, made it her business to make sure she could use the tablet at the bedside as well as anybody, and she became the go-to person for everyone else. So you want to look at technology proficiency. You want to look at what other projects are on the horizon. We all have a number of projects that the hospital is trying to implement simultaneously, so you want to make sure that you have enough resources to cover all and that the timing is correct. What is your staffing mix? Do you have a lot of contingent or contract staff? How committed are they to making a new initiative work? When are they leaving? Are you going to have to train new people 3 weeks after you go live? You're going to want to pay attention to that. And then again, general staffing levels. Going live on July 4th weekend when volumes are high and staffing is low may not be the most optimal timing. And then it's important to define where you are right now. Collect as many metrics as you can now so you know where you want to go. It's good to list all of the issues you think are contributing to suboptimal patient flow or suboptimal patient experience. And some of these can be impacted by technology and some cannot. So do you have a high cost relating to dictation or scribe? Is your dictation turnaround and accuracy what you want it to be? Part of the reason we went to an EDIS at Henry Ford is because our dictation turnaround time was getting up into the range of 36 hours, and so our admitted patients did not have any information flowing into the system. Do you have illegible records, incomplete records that are taking up a lot of clerical time to get those either found or completed? Are you undercoding relating to this? Long length of stay? Do you have way too many people in the emergency department for the space you have? Is there a better way to use the space? Are you holding a lot of admitted patients? We all have that issue. How clean is the waiting room? How adequate is the staffing? What's going on with patients? Are there errors or risk issues? Are you meeting the regulatory requirements? Are you getting the information across to the next providers, whether they're in the inpatient or outpatient setting? Do you have wide variability in your practice style and documentation style? We had some people who would dictate a half a page per visit and some who would dictate 5 pages. And it didn't relate at all to the quality of care provided, simply about the documentation. We had people who ordered very few tests, people who ordered a lot of tests. So it's important to know, once you list all of your issues, what is it that technology can help, and what aspects of the issue can technology help? And then you have to consider potential for new issues to arise with implementing the technology. So whereas an EDIS may not improve your staffing or increase inpatient beds or keep the waiting room clean or get a blanket for your patient, it will decrease error, decrease variability, increase accessibility and legibility of the charts, increase the flow of information, etc. Important to really brainstorm and look at all of the issues, put them all on the table. So once you've looked at your issues and prioritized which ones are most important for you to address, you can start lining that up with the products that you're looking at. So you want to look for some key attributes. Is the product intuitive? Now, when you go into somebody's kitchen, you figure that the the cooking utensils are near the stove, the glasses are near the sink, and if everybody's kitchen is set up that way, you can easily find things. If somebody's kitchen is not set up that way, you're looking through every drawer before you find what you need. It's sort of like this with documentation and EDIS in general, that you want it to be something that most people could figure out how to use even if they had no training at all. You want it to be flexible, because as we all know, our patients do not follow a script when they come in to see us. They may come in with a chief complaint, stubbed toe. You ask them why they're here. Well, their mother had cancer. Okay, there's family history. And they were visiting her in the hospital and went out to smoke. Okay, there's social history. And they get headaches all the time. Okay, there's past history, but this was the worst headache of their life and they passed out. Okay, that's good information. And they stubbed their toe. So it's important to be able to follow the patient rather than forcing the patient into a script, because you may lose some valuable information. You want robust ED-appropriate content so that you don't have to be typing all the time or dictating an addenda. You want it to be right there in front of you. You want to be able to provide, to have communication between team members and alerts and feedback that don't interfere with workflow. You want them to support workflow. So there may be some gentle reminders like we have up here that certain labs are back or certain orders need to be implemented or that certain information has been added to the system. But it's a visual cue. It doesn't interrupt your flow. There may be a more significant alert that you need to look at when it comes to ordering of meds and allergies or ordering of medications. And then here's another subtle way to alert somebody that something's going on. But again, they can choose to look at it or not look at it. So when you're looking at EDIS functionality, you're going to be looking through several lenses: workflow, data, documentation, etc. So when you're looking at workflow, you want to make sure that there's EMTALA compliance. You want to allow for non-sequential parallel processes. We know that emergency medicine is a team sport. Lots of people doing things simultaneously in many cases. So you want a system that will allow that. You want a system that will give you some feedback regarding bottlenecks so that you can manage the emergency department real time. And relating to this, you want to be able to identify certain milestones that have exceeded thresholds so that you can intervene. Again, visual cues regarding next steps in workflow. You want seamless transition of care at the end of the visit. You want to be able to streamline and standardize order process. So order entry, order sets are important. Clinical documentation. This, again, I can't emphasize enough. This frontline provider usability for the product is so important. So you want documentation that's consistent and efficient. so that when you are documenting the same types of things, you can find them in the same place and document them in the same way. And that allows you to develop some muscle memory so that you don't have to recreate the wheel and be looking in every drawer every time. You want to reduce or eliminate free text. And for the younger docs who are great keyboarders, this may be less of an issue. However, there are other reasons for not wanting free text. And the big one is data. A lot of data can be codified and utilized for future reporting, whether it's for resource utilization, whether it's for compliance, regulatory compliance reporting, or even research in academic sites. And the other reason that codified data is important is that as systems develop additional functionality, there's going to be clinical decision support that's related to this codified data. So if you maybe document that the patient has chest pain and is a smoker, there may be some information delivered to you that allows you to make some good decisions relating to their care. So you want documentation that helps providers make evidence-based decisions faster and easily document their medical decision-making in ED course. You want the next physician or next provider, next nurse to understand what happened in the ED and why. And then you want to be able to present the information on a single plane so that if the patient jumps around or your thought process jumps around, you can support that with your documentation. You want screens that match workflow is the bottom line. There are several things that can decrease efficiency. If you're typing a lot, if you have excessive scrolling, nesting, pick list, alerts, etc. So here are some examples of that. Data integration is very important. There's lots of data out there. There is no need to re-enter that data. So you want a system that's going to be able to pull that in without a problem. Functionality management and reporting. Now this is exciting to the administrators, and it really does help. There are a couple of types of reports. There's the retrospective reports, and there is the real-time data that allows you to manage minute to minute, hour to hour. And there is all sorts of information available about throughput, about staffing levels, about certain areas of bottleneck, inpatient beds, etc. So you would like to have this in order to effectively manage your ED. So you also want to understand the requirements, both your requirements and the vendor requirements, hardware, software, staffing, interface work, training, content build time, customization time, and requirements. Very important to look at what the vendor requires in order to use their product and what you can provide. There are certainly pitfalls in selecting a partner in this EDIS project. When they say that you have complete ability to customize, that means that you're going to be building a lot of the content and infrastructure. They're just going to provide you with a shell. When they offer stage deployment, implement our tracking system now and we'll get to the rest, be very wary because the rest may never appear. And this is also related to vaporware. If it doesn't exist, if you don't see it, it doesn't exist, and you want to be able to ask where it is deployed and how is it being utilized. You want to put the product in people's hands because salespeople are trained to make it look easy. So you want to actually either go to a site or at least be able to try it out to make sure that it's usable. And then you want to check resources. Class is a good one. You can ask for other site referrals and talk to them. You want to know about the company. What's the primary focus of the vendor? What resources do they have, both clinical and technologic? What's their business history? What's their customer service rating? Because this is not just a purchase of a single system. You're developing a partnership with a company, so you want to know about their long-term commitment. And then finally, you're going to want to create an ROI, setting baseline performance and capturing some metrics. So for facility metrics, you're going to look at your volume, your revenue for admitted and discharged patients, length of stay. You're going to look at how many infusions are downcoded or not billed, denied radiology or lab claims, all those charts that are lost, not billed, undercoded, how much clerical and coder time is it taking to rework charts. And then you're going to want to look at your payer mix. From the physician standpoint, you're going to want to look at cost of dictation or paper, how much time and energy is spent finding lost charts, looking at clerical FTEs, and then looking at your coding distribution. Now, this is one hospital's results with T-System EV. They realized they got 8 times their ROI. They reduced turnaround time on radiology and lab, improved infusion charge capture, improved support for facility charge levels. So their payback period was 4.3 months with an investment of $189,000 year one. Their three-year ROI was 744%. So pretty darn good, and we have other information like that can be provided. So in summary, you need a multi-pronged strategy to assess throughput issues. Your ED information system is just one. Technology alone is not enough. You need planning and process improvement and leadership to make the most of it. And not all technology is created equal. So you really want to look at how it supports your workflow and how it supports your goals. All right, we're just about at the end of our time, but we probably have time for a couple of questions if there are any. And part 2 is going to be on October 11th, if you'd like to join us.
All right, thank you so much, Dr. Anderson. As I mentioned before, if you do have any questions for us, feel free to go ahead and type them in the Q&A box. We do have 1 or 2 here, so we'll do those. And if you have any additional questions, feel free to go ahead and type them in right now. The first question is, we are able to make a strong case to get administrative and IT buy-in, but how do you get the clinicians to buy in?
Oh, this is a good one. Actually, at our facility, the clinicians drove the decision, but there are certain benefits to clinicians that you can talk about. A big one from a day-to-day perspective is accessibility to the chart. You're not hunting all over the emergency department to try to find out what the orthostatic vital signs were or if a medication was given. If you're currently hand-producing prescriptions, instructions, orders, all of that becomes a lot easier with an electronic system. Order entry is really a big positive impact for clinicians because they can generate orders at the touch of a button right at the patient bedside. If you're coming from a paper system, an electronic system offers you more real estate, and you're able to pull in information from other systems, so you're not duplicating your efforts every visit. And then, of course, reimbursement is a big one for clinicians.
Okay, thank you. The next question we have is, do you have any thoughts regarding a best-of-breed solution versus an enterprise solution?
Well, this is the ongoing question. Of course, enterprise systems are touted to be fully integrated, although that may or may not be the case. You know, an enterprise system may be just a collection of best-of-breed systems that were cobbled together by the same owner. I mean, you do have some standardization and kind of similar look and feel across all the elements, but there's typically less functionality for the areas that really need specific things to support their processes. So you may spend less initially, but then you're spending money to add functionality or to customize to certain subsets. Best of breed clearly supports the needs of a specific niche. So for emergency medicine, you know, we have a lot of very specific needs that nobody else in the hospital has, and we cannot really tolerate inefficiency on a long-term basis. So Best of breed works for emergency medicine because there's more functionality and it's a more complete system. And the downside in the past has been the ability to integrate, but that is really essentially going away. And you want to be looking at what does integration mean. You don't really need to fully integrate every single aspect. There are certain subsets of information that need to be passed back and forth. There's this idea of data virtualization now, where basically data from disparate systems are kind of put into a cloud and then accessible from all systems. So I think that's going to counteract any integration issues that people may have in theory about best of breed. So you're going to, the bottom line is you'll do what's best for your organization and your department overall.
Okay, thank you. It looks like that's actually all of our questions, and we are just a little bit over the time limit here, so that will be the end of today's webinar. Thank you so much for joining us, and again, please see your screen for information on how to register for Part 2. Thanks again. Bye.